Welcome back to people that are in the audience on Facebook and on Twitter. We are live from the Arthritis Broadcast Network studios here at the 2020 Canadian Rheumatology and Allied Health Professionals Association annual scientific meeting happening in Victoria, British Columbia. We are fortunate to have a number of guests that will come in during the course of the days that we're here, but we are particularly happy to be able to welcome a great guest today. So Dr. Deborah Marshall is a professor at the University of Calgary, a renowned researcher, and has done an awful lot of things recently in relation to arthritis. We're going to explore some of those things with her. She, just as a bit of a background, she is the Canada Resident Chair of Health Services and Systems. She is the Arthur J. Charles Chair for RA Outcomes. For the audience, these are big deals that she has been asked to be able to do these things. And she sits on the board of directors for the Arthritis Alliance of Canada just in her spare time as well. Welcome, Deborah. Thank you very much for coming in to talk to us.
Well, thank you for inviting me, and you guys are the big deal.
Well, thank you very much. We're easily flattered on occasion ourselves. So there are a couple of things we wanted to talk about. One of them was that you did a presentation here recently, the reason, in fact, that you came to Victoria, and it was of interest because you were looking at the province of Alberta, where you're actually at the University of Calgary, and you were looking at some differences, geographic differences for people that have to deal with their chronic diseases in Alberta. Can you tell us a bit about that?
Absolutely. So this was specifically looking province-wide in Alberta, and what we were doing is using something called geospatial analysis to look at what is the prevalence of rheumatoid arthritis around the province. So as opposed to just looking at the total rate, how does that map out? And I did have a very nice colorful map in terms of where there are what we call hot spots.
Okay.
And also thinking about the rural-urban continuum. Because as you know, access to rheumatologists and having specialty care for patients who had rheumatoid arthritis is really important.
Yes.
So that we can diagnose early and also manage and monitor treatment to make sure that the disease is being managed appropriately.
Did you find hotspots?
We found 7 hot spots, lucky 7. And what's interesting about the hot spots is that they're all in what we call rural and rural remote areas. Not surprisingly. I mean, A, there's geographic variation, which is what you would expect, and B, it's the rural and remote areas where we see hot spots. So in some cases, that can be up to 5 times the rate that we would see on an overall average for the province. So the issue then comes down to how do they access care?
Is it because they're not accessing care that the hotspot exists in the beginning?
Well, so we use administrative data, and these are people who have been diagnosed with RA based on a validated case definition. And so we haven't looked at the accessing of care yet. That's step 2. You've got the future research direction so that we bring together the information about where the people are who have been diagnosed with the disease, and then what we'll do is match that to, well, where are the services available, and then we'll also be looking at the distance, time, travel it takes for them to access those services.
Do you believe that if once you have this information, who do you think will actually make the most use out of it?
Yeah, so our research team actually does include not only researchers and rheumatologists, but also hopefully the idea is that we have knowledge users from a health policy and planning perspective. So in our province, it's the Alberta Health Services. So they're also part of this because they need that kind of information to think about how do we plan for services and needs of different populations across the province, because of course they are responsible for the whole province and they have a mandate and a goal to try and reduce inequities in care. People in rural and remote may have inequities, and there are disparities potentially. This is what we're trying to identify because they have to travel long distances.
Yeah. You also have a focus on some of your work on the actual patient experience, the kinds of things that actually impact patients. I understand you were doing some work on that as well.
Yeah, so I'm really excited about that. We've done work in the area of what we call patient preferences for close to 20 years now, before it was actually applied much in health. And it's actually a really exciting time now, because after a long period of really trying to think and develop the methods in health applications, we're now at a stage where we're actually seeing and working on how you can actually use that information in decision making. And one of the most exciting things in the last few years for me is that regulatory bodies are now recognizing information that we gather through these methods called patient preferences, where we're looking at how do people trade risks and benefits. They're recognizing that as evidence in submissions. We're starting in devices, but it may be that in the future this moves to other products and things. So it's a pretty monumental change in thinking that you could actually have that as part of the evidentiary package to get products approved.
Okay. So what kind of adaptations are that are people making in order to be able to get by from what your research has shown?
Can you explain what you mean?
Well, if you were mentioning something about the trade-offs that they're forced to make, yes. So what kind of trade-offs are they making?
Absolutely. So we have a project called Understanding Childhood Arthritis Network. So this is research that's across Canada in childhood arthritis. So one of the areas where we're applying this method is to think about how, when and how, and what would be the trades to think about tapering or stopping treatment with children. So the trades would be the benefit of not being on medications and the potential side effects associated with those medications, and also the psychosocial sort of idea of being on medications, potentially for a lifetime. And then the risks are that if you taper that medication, you might have a flare. So the kind of research that we do with preferences is saying, okay, what percentage increase in risk of having a flare would you be willing to make
yes.
In order to come off a biologic?
Oh, I see. So those are the kind of decisions that people have, and if they're going to make those decisions, at least they'll have something to work from to make a better decision. It will be. Yeah,
because using these methods, we can identify what's important to patients, and then it also gives us a way to quantitate it, because we can put numbers around these trades. So it's a way of actually bringing, and informing a really good dialogue about what's important to the patient, both from when they're talking to their physician, because it makes it very explicit, plus when we're looking at getting approval of drugs or treatments or devices, we can start to bring that evidence into play for the dialogue and the discussion. Yeah.
You're also going to do a webinar?
I am. Yes, actually. You know a lot about me, Dawn. But I was telling Dawn before we came in that I was really excited because we're doing a webinar that's really about this whole topic and how do you use information, how do you take this kind of methodology, I'm a researcher, right, and this is relatively new in health still. How do you take this kind of methodology and bring it into the decision-making process? What are the ways we can do that? What are the cautions? What additional information do we need? So this is in collaboration with the Food and Drug Administration, and also I belong to an organization called ISPOR, so it's the International Society for Outcomes Research and Pharmacoeconomics. It's a long title, but we have a task force now, which includes bodies like the Food and Drug Administration, to look at, well, what really constitutes scientifically valid but also relevant information that can go into these decision-making processes. So it's really exciting to see that moving forward.
You did some work in Europe as well?
Yeah, in my past lives, you mean?
Yes.
Yes, I have. I am Canadian, but I've had the privilege of having the opportunity to work for health technology assessment agencies in Canada and also in Sweden, and actually trained in my doctoral training in the United States. So
You've been around?
Oh, I was hoping you weren't going to say that. That can be misinterpreted.
I took that back. You've had a well-rounded education?
Thank you. Yes, I have. I've had a diverse exposure to different geographies and employment settings.
I'll write that down so we can put it in the future. So the number, your response to the webinar that's coming up, there's been a good response to this.
Yeah, well, actually, when we set it up, this was as a precursor for an in-person summit that we're doing in Washington in 3 or 4 weeks. And there is a certain amount of space, and so part of this is to get people kind of on the same page. And there's already 700 people signed up for the webinar, so I guess it's going to be a big audience that we won't see. But anyway, so yeah, we're excited about it.
This sounds like you have a very busy career pattern, and you certainly, from the kind of respect you have from your peers and the organizations that actually have looked to you for the kind of guidance that you have, you're to be commended for the research work that you have done. Do we have any from the audience, any questions?
Yes, for people who want to set up a traveling rheumatological clinic to help these people access healthcare in remote areas, what information or what resources are there to help them set this up?
Yeah, so, well, I think there could be many resources, but some that I can think of actually would be, we're sitting at the Canadian Rheumatology Association, for example, and there's different committees, and I'm probably going to get the exact committee wrong, but they do have committees that are concerned and have an interest in trying to make sure that people have access to care. So I think this is a potential resource actually right here at the CRA through the association, that if they can't directly support, so to speak, that activity, they could certainly connect people to the right contacts across Canada, because as you know, there's several places that have these remote kind of clinics and traveling rheumatology services across Canada. So
we do a number of them here in British Columbia, and they seem to. I know of a number of rheumatoologists, for instance, whose patient load actually includes an entire community in another place. So they have their own patient load here, and then they have adopted one or two other communities, and they simply take on everybody that's there. Sometimes 3 or 4 days and 100 patients at a time. I know that some of them have done a lot of patients.
Yeah, and we have a similar kind of thing in Alberta. And I don't know every provincial arrangement, but I think those kinds of services are available in most provinces.
What do you see about demographics in the rheumatology space? Are we replacing the rheumatologists as they retire? Are we getting enough rheumatologists to come on stream?
Interesting you ask, because a few years ago we did a study called Stand Up and Be Counted, and it actually looked at the patterns, and relative to the benchmarks, we could use more rheumatologists. It is a great career path for any young aspiring rheumatologist out there.
We've been telling them
Good. So I think, there are opportunities, and actually we've had a really good influx of people who've been interested in the last couple of years. But that survey did show that there was some concern, because there's sort of a number of rheumatologists who are planning to retire in the not too distant future. So there will be an even greater need, I think. Now, also, it was just announced at the CRA general meeting where I just came from that they've updated that survey now for 2020. So it'd be interesting to see where the gaps are and where the needs are.
We hope that they're successful in making, because we did fear a gap a few years ago, that we were going to end up in a gap. Any other questions? Well, this has been a very interesting talk. We're very pleased that you could come in and share your stuff with us. This was it was very, not only entertaining, but also very informative for us. And of course, coming from a patient-centric organization that we are, the idea that you are also looking at things for directly affecting patients is heartening to us. So on behalf of us all here in the Broadcast Network, we thank you for coming into the studio, Professor Marshall, and we hope you enjoy the rest of the conference here while you're here.
Thank you, Don.
Thank you.